Good day. My name is Dr. Noland Naidoo. I'm a prosthodontist in Sandton, Johannesburg. Thank you for this invitation to share some of the cases that we get to treat in our practice on a day-to-day basis and some of the links to the successful outcomes that we've put together. I hope you enjoyed the presentation, and if there's any questions, my email is at the end of the presentation. You can send me an email. Links to successful outcomes and optimizing implant aesthetics. So before we start, I'd like to just provide you with some disclosure. I have no financial interest with Sudden Implants or its products, but I am sponsored by Sudden Implants to provide this lecture. However, the views expressed during this presentation are solely my own and do not necessarily reflect that of Sudden Implants. So I believe that the best way to talk about any concept is to show you cases that I see on a daily basis. And here's a case that walked into my surgery a few months ago. Referred by the general practitioner, the patient's unhappy with the crown and the tooth recite, and you can clearly see why. So this patient had undergone orthodontic treatment, and the tooth tree was removed, and immediately placement of an implant was provided for the patient. However, in the last 2 years, this crown constantly has debonded, and the patient is unhappy to keep going through this process, and now the crown is also fractured. If we look at the radiograph of this situation, you can clearly see that the crown isn't adequately seated on the titanium abutment that was provided, and there's a bit of excess cement, which we can see clinically and radiographically. Whenever we see these cases, the first things we ask ourselves is, why? Why has this happened? How can we correct this? And what can we do in the future to prevent this from happening? So starting with the why. When we look at the 3D position of the implant, we know from Boozer et al. And a few of his other colleagues that when an implant is placed in an aesthetic zone, there are some rules that should guide the placement of the implant. When we look at the coronal-apical position, we should ideally have that interface of the implant 3 to 4 millimeters subcrestal to the planned position of the apical part of the restoration. If we look at this case and we mimic the canine on the other side, we can see that the implant is perhaps not placed deep enough, which is why we have this short emergence. But if we also look at the orofacial position, one of the reasons that perhaps it was a cement retained crown versus a screw retained crown is that the implant was a bit too buccal, and perhaps the screw axis was also a bit too buccal. Some of the other rules that we need to adhere to is that we should at least have 1.5 millimeters of bone between the implant and the tooth, which we do have in this case. And if there's adjacent implants, we must leave at least 3 millimeters of bone between the implants. Thankfully, not an issue in this case. Something that people rarely talk about is the screw access channel. So if you want to screw retain a crown, and we should want to screw retain the crown, we need to remember that that channel is 2 millimeters in diameter. And we need to allow for that in the reconstruction or the planned reconstruction of our crowns. Then we look at the diameter of this implant. So we know that this is an immediate placement, and canines generally have large roots. This is a 5 millimeter in diameter implant. So in the past, we would want to have the biggest implant fill that bony alveolus. But now that we've done a bit more research, we know that we're trying to respect the biology, and we want at least 2 millimeters of native bone around the implant. So this implant is a little bit too wide for this alveolus, which could be the reason why we see the marginal bone loss at the crestal level. Now, what could we have done? Because obviously they wanted to immediately load this implant because the patient didn't want to walk around without a tooth. And whatever the planning was at that stage, that was the plan. So how could they have gotten good primary stability, but also respected the biology? Now we look at the evolution of implant placement and loading protocols. And we look at the last ITI conference consensus, where they look at immediate placement of implants is a treatment of choice when the condition allows. How can we aid that condition to try and get it right every time? So Sudden Implants has a few novel ideas in the armamentarium of products. One such product is the new inverter implant, which allows us to engage the apical portion of the alveolus to get good primary stability with a wider body implant, but then respecting the anatomy at the coronal portion by narrowing the implant body there to allow us to have better orofacial buccal width of the bone. As we see in this video that's about to play, when the tooth is removed, the apical portion is much wider than the coronal portion. And if we had to place a traditional implant, we can see that we may just be infringing on the bony envelope at the coronal aspect. With the new design, we're still getting good primary stability from the apical aspect, but now we have much more volume at the coronal aspect to give us more predictable results and hopefully less complications. So if we had to use that implant in the previous case, we could have possibly avoided the complications that we are now currently faced with. Let's look at another case, one that I was fortunate enough to treat from inception. Here's a young lady that had fractured her 1-1. She's currently wearing a partial denture, as we can see in the radiograph, but wants to replace it with something more permanent. With the cone beam scan, we can clearly see that we have a reasonable amount of bone volume, but the root's ankylosed. So if we had to remove the entire root, we might be losing some of that bony alveolus. So how do we then treat this case? So here we have the surgeon removing the root, leaving the facial part of the root behind, placing the implant, the new inverter implant. And as you can see here, implant's well placed with enough orofacial buccal width, and the soft tissue is kept intact. We're fortunate enough to take a cone beam afterwards, and we can see that the implant's perfectly in the middle of that alveolus, and we have good bone circumferentially around the implant. That allowed us to then immediately load this case using the Sudden Implant's peak abutment and a bisacral temporary material, and we've mimicked the tooth in the 2-1 site, trying to give her optimal aesthetics. After a period of healing, the crown is then converted to a definitive crown, and we have a happy patient. Now let's get to cement retained crowns. It's been a controversial issue for a long time, but hopefully now with the current literature, this has been put to rest. If we want to cement retained crowns, Agar said in 1997 that the abutment needs to be no more than 1 millimeter submucosally. If it is, you risk leaving excess cement behind. Then Wilson in 2009 showed that excess dental cement was associated with signs of peri-implant disease. And then Thoma in 2018 said that cemented restorations exhibited higher bleeding and probing values than screw-retained restorations, and the number of inflammatory cells was 50% lower for screw-retained restorations. Cemented retained restorations also exhibited greater prevalence of serious biological complications, and this was shown well with Saylor et al. In 2012. So whereas cement retained restorations is an option, is it an option that we want to use for predictable outcomes? Looking at this case, how do we then treat the situation? How do we help this patient not repeating the errors or the complications that she's already had? So the crown was removed and we constructed a provisional restoration. But we can clearly see in the provisional restoration reconstruction that the screw access hole comes out right in the incisal edge. thankfully with the provisional restoration, we were able to aesthetically camouflage it with a composite restoration. But we know that these composite restorations do tend to discolor, and is this a long-term solution? We left the patient with this restoration for the next 6 to 8 weeks to allow the soft tissue to mature around it, and upon follow-up, we then had to make some serious decisions as how we were going to then reconstruct her definitive restoration. What are the options? We could try aesthetic screw access closure, but there are some limitations there. We could get fairly good results as shown in another case of Professor House's. We could also try a secondary retaining screw, but these are quite complex reconstructions, especially from the lab aspect. And as you can see here, these need to be cast, and perhaps not the best solution for this patient with a high smile line. Angled abutments are another option, but as we know from angled abutments, they also have their own complications, and generally you have this polished collar, which in this case we would not be able to hide. What about angle screw channels? So there's quite a few products on the market where we can then change the angulation with this fancy abutment. It's a very nifty idea. And we know that the aesthetic outcomes from this article are comparable to cement retained crown, so we're not losing anything. Recently, sudden implants have developed their own angle screw channel abutment, and in the past there's been some skepticism with angle screw channel abutments because of the screw loosening associated with it. And this study, or this article here, shows that actually the one by sudden implants that has less screw loosening, and you're able to torque it up to 32 to 40 newtons without any issues. So here's the temporary crown again, and a definitive zirconia crown in the mouth. This is a much better situation for the patient, and hopefully will give her less complications. We have a favorable screw access channel, which we can then mask behind the crown and close with the composite restoration. And if it does discolor, it does not affect the aesthetics of the crown. And a happy patient. Very good laboratory work from my ceramist. So sudden implants have a few abutments that we could use for either mold and cast implant restorations. Well, what does the evidence tell us? So what do we need to know when it comes to using these abutments? We need to choose the right abutment height to allow for optimal emergence profile. In this case, the right abutment height is the shortest one because of the position of the implant. But if we look at this picture with the abutment superimposed clinically, it's quite short. Now, if there's a tooth-supported crown, would we be happy with that height? Would we cement a crown on an abutment of that height? And the answer is no, we wouldn't. So why would implants be different? So if we look at the options available, we'd actually want one with a longer collar that then extends the chimney and more favorable crown to abutment height for cementation. Thankfully, the sudden implants angle screw channel has a longer chimney, which can be customized. So even if you choose the shortest abutment height, as we would have had to for this patient, we then could customize the length of the chimney to optimize the screw retention. As shown here in this illustration, where we superimposed the chimney onto the crown. But is there any evidence? So currently we have a numerous amount of materials on the markets. There's ceramic silicates, and there's polycrystalline structures such as zirconia. And not all zirconia is equal. We have the more translucent zirconias with different fracture toughnesses, and then the traditional 3Y TZP zirconias with the highest fracture toughness. And when we choose either of these materials, we have to understand that we have to manage them differently. So the group from Geneva has done some good research to look at the differences between zirconia and lithium disilicate cemented onto titanium base abutments. And they found that there was very little difference between the two if the right protocols were employed, and up to a 98.3% survival rate. So should we be sandblasting our abutments? And some schools would say no, and others would say yes, but what does the literature tell us? So another good research project done from the University of Geneva with Peter et al., and they looked at 4 different groups: a control group, a group where they sandblasted the abutments with 110 microns of silica modified particles, 30 microns of silica modified particles, and 50 microns of silica modified particles. And the results are quite surprising. They found that when we used the 50 microns of silica modified particles, it gave us the best bonding result, with only 7% debonding versus 73% debonding when no treatment was done. So should we sandblast the titanium base abutments? And the answer is yes, we should. And we also know how we should do it with 50 microns of aluminum oxide. What about cementation? What cements should we use for the crown restoration? And it depends on the material that we use. So here's another study done by the Geneva group where they looked at your enamic blocks or your polymer infiltrated ceramic network blocks, your lithium disilicate blocks, and your zirconia blocks. And when you're cementing lithium disilicate, multi-lick hybrid abutment cement came out the best. It showed that it had the best bond strength. But when we were using the polymer infiltrated ceramic network blocks, actually Panavia was better. Or Rely X, they were very close, neck and neck. And zirconia, which is something that we're using more and more routinely, Rely X Ultimate from 3M showed to have the best bond strength. So when you're choosing your material, also got to realize that we have to choose the right cement. And this is often evidence that's not shared with the lab. This is something that the clinician gets to do on a daily basis. And this is the information that needs to be transferred to the lab. So when we choose the material, we must choose the right cement. And this is a very nice slide to show in a very straightforward fashion how to choose the right cement. Well, what other abutments are available? Sudden Implants also has a passive abutment, which was originally designed for cast restorations, and then with the advent of milled restorations, adapted for that quite easily, I should say. So let's look at this video that shows us what a passive abutment actually is and how it helps us. Alright, so here you can see we can use it for monolithic milled restorations as well as cast restorations. And with casting, we know that every time you put something in the oven, you oxidize that metal component. So this component only gets put onto the restoration right at the end after it's done being processed. And in the lab, we then lute the component to the restoration with the correct resin cement, clean it up, polish it, and deliver it to the clinician. And here we can see that the prosthetic screw clamps the whole complex together, not relying on the height of the chimney for retention. All right. So what would we have done, or what can we do in the future to prevent this from happening? And it all starts with planning. Benjamin Franklin said, if you fail to plan, you plan to fail. And planning can be done in an analog fashion or a digital fashion, as shown in these two cases. The use of cone beam tomography is essential in the placement of any implant, so that when we get to surgery, there's no guesswork. We know exactly what we're going to do, we know exactly which implant we're going to place, and the angle and 3D position that we need to place it in. And if any augmented procedures need to be done, those can also be planned for. So we have a more predictable outcome, and the patient knows exactly what to expect. What about guides? So how do we translate our planning to the real world? And we can do this via analog guides or digital guides. But there are many guide systems on the market, so which one should we choose? And the answer is a very difficult one because they all really work well. And so you would choose the one that you've done the most research on and the one that you understand best. And probably one that comes with the implant system that you use, if possible. But common sense is essential when using guided surgery. I love this slide, which says that if you hit the sign, you're going to hit that bridge. And that's kind of what you need to approach implant surgery with as well, with lots of common sense, in understanding that sometimes you can't always trust the guide. So there's a lot of literature in dentistry on digital guides, on digital planning, and digital workflows. There's over 4,000 articles published in dentistry on a yearly basis, and quite a few of them on digital workflows and digital guides. So what did they actually say? When you look at this consensus statement from the ITI group, they say clearly that digital guides or surgical guides are an adjunct, not a replacement for appropriate diagnosis and treatment planning. It always needs to be prosthetically driven, crown down, and you need to allow for 2 millimeters of leeway in the plan. And we'll see why just now. When you want to approach this with a flapless approach, you need to approach it cautiously. Because of this 2 millimeters of leeway, in tight situations, you could not recognize something that's not going well. And fully guided implant placement does improve the accuracy, but again, you need to be able to check this. So let's look at this video from my friend Alan Yap in Australia, where he looks at the different guided systems. And here we can clearly see the amount of leeway that each system produces. And this is an engineering design that has to be incorporated into this design system to allow for the drill to pass through the sleeve without binding. Now in the novice's hand, someone that hasn't placed a lot of implants, it's very easy not to recognize when you're in the wrong position. And I would say that guided surgery is more for the intermediate to advanced user rather than the novice user, for this reason alone. Let's look at this case. A patient presented to us with a discolored tooth. When we look at the periapical, we can clearly see there's a horizontal fracture subcrestally. The patient had previous root canal treatment, and the previous dentist seemed to have tried to retain the two segments together with a fiber post, which clearly didn't work. We go back to our planning. You can see that the root encompasses or takes up almost the entire alveolus. And if we had to try and place something such as the inverter, in this case, it may just be encroaching on the biology of this patient's alveolus. So we had to use a smaller implant if we want to try and maximize the amount of bone volume around the implant. And this is why planning is critical. Every case is different, and every case needs to be planned on its merits. Sudden implants have their own guided system, called the serial guide surgery system, which is very novel. And let's watch the video explaining what the guide system encompasses. The cannon, or the placement tool, is a very novel design which can then incorporate any of your original drills. So you don't have to buy special drills for this system. You just need the cannon driver. With the offset sleeves, and this is something that you would plan and decide which offset sleeve you'd want to use for that case. And this offset sleeve gets screwed onto the cannon driver. Then your drill is inserted into the cannon driver, and the ring at the top is turned to secure the driver or the drill. no more fiddling with extensions in theatre. And here we can see how the offset changes depending on how you planned. And now we're going to go through the drilling protocol. Site is opened. And we start with the guide and the spade drills. And this fits straight through the guide. Next drill placed. And your drilling sequence continues. The surgeon then gets a sense of what the bone quality feels like, or the bone density feels like, and decides where he wants to stop his drilling sequence. And then the implant's placed through the guide. A healing button placed, and then allowed to either heal or ready for immediate temporization. So how did we approach this case using that system? The tooth was removed, the patient was anesthetized, the root was left behind. The surgeon then removed 90% of the root, leaving the facial aspect intact, employing the socket shield technique. The guide fitted. Here we can see that we have little areas in the guide to allow us to ensure that it's well seated. And then the surgeon drilling through her drilling sequence. I always have an analog guide as a backup because the surgical guide helps us with the drilling sequence. But from a prosthetic point of view, I still want to know if we are in the right place. And here we can see in the bottom left-hand side that we are happily in the right place according to the patient's original tooth position, which we were replicating, and the screw access is perfectly in the cingulum area. We then placed this implant without the guide in place. The surgeon was fairly confident that she knew where she was going. But during placement, the implant kicked a little bit and was a little bit more palatal than I would have liked it. But the depth was perfect, and still an acceptable placement result. And here we can clearly see the remaining tooth segment on the buccal. Provisional restoration was then fabricated using the patient's original tooth and a PEEK abutment. The surgeon then grafted the jump gap and the restoration placed. And here we can see on the right hand side the restoration in place immediately after surgery. Again, when we look at the cone beam scan, you can see a fairly acceptable result, perhaps a bit buccal, but still acceptable and stable, and a very happy patient. So let's go back to the literature, because we talked about digital. What do we then do after the provisional restoration has healed and the soft tissue has matured? We've spent all this time being as meticulous as we can. How do we transfer this soft tissue information, the implant position, to the laboratory to then fabricate a definitive restoration? So there are digital methods of doing so, and they're getting better and better. And sudden implants have their own impression coping, which here we can see is roughened so that even though it's metal, the scanner still picks it up fairly well. But I'm just not yet happy with the soft tissue capture. There's a little bit of guesswork still with the software that doesn't give me that perfect soft tissue emergence. So I go back to traditional methods when I am restoring definitively, where we duplicate the emergence of your provisional restoration. And this gets transferred to the technician. Here we can see it clinically, checking to see that it fits well, and I'm still happy with the soft tissue support. and a customized tray, and a customized impression to give us predictable aesthetic outcomes. So what information are you receiving from your clinicians? Interaction and communication are the only way to gain these optimal outcomes, and we should be communicating with our dental lab on a continuous process during the indirect workflow step. So in this case, you can see that lots of photographs are taken and sent to the technician with all the different shade guides. During the try-in step, I'm also communicating exactly where one thinks to be adjusted. And this is a little bit of back and forth, but this is a step that shouldn't be rushed. We've spent all this time being meticulous, and this is the part the patient sees at the end for the next, hopefully, 10 to 15 years. And we should be meticulous in this, and the only way to really get results like this is to communicate with our partners, who are you guys, the lab technicians. Because you don't get to see the patient, we do often. And so how do you know what we are seeing, and how do we communicate what we need to be changed? And that's through communication. Laboratory prescriptions also need to be succinct, not a scribble on a page, where we give you as much information as possible. And there should be audits back and forth, where this communication is either verbal or email, and we live in a digital world where the cell phone is easy to pick up and send a message, so that we both know where we're going to, and if there's any complications, we can anticipate for these. So when we interface with our laboratory, the clinician needs to involve this technician in the planning and clear decision making, because often I find that the technician leaves it up to you guys. The clinician leaves it up to you guys to make the decisions on the guide and the material, but this should be a shared decision making process. You need to understand exactly what we want with the right information, and we need to give you complete and precise information about components and the impression and the color analysis with either pictures or other forms of communication. And checklists will really help us, both on the clinician side and the technician side, to ensure that we're being consistent and we don't miss a step. Constructive feedback is always welcomed, it should always be welcomed, because we can only learn from our last case. Communication is key. So in summary, what are the links to successful outcomes? It's shared evidence-based decision-making that needs to be made with the entire treatment team, not just the clinicians, but also the dental technicians. We need to place that implant in the correct 3D position, and we need to understand the implant system and componentry to aid us in the right selection of the correct componentry to engage in the correct workflow. And the selection of the restorative material and cementation protocol needs to be according to the correct clinical indication, and then needs to be handled correctly. With that, I say thank you very much for your time and attention. And again, if you have any questions, please email me in the email address below.